Good afternoon and welcome to today's webinar, SARS-CoV-2, Rising to the Testing Challenge in the United States. My name is Joyce. I work at the American Association for Clinical Chemistry and I'll be your moderator. I'd like to point out that this webinar and the following Q&A session has been recorded in advance and can be stopped and started at any time. So let's get started. We're delighted to bring you this education presented by AACC and generously supported by Roche Diagnostics. As a global leader in healthcare, Roche Diagnostics has made the promise to empower laboratories and the people within them by providing clinical and strategic insights, support, and solutions from the industry's top innovators. Today's webinar presentation is SARS-CoV-2, Rising to the Testing Challenge in the United States. Please welcome our presenters, Dr. Stephen Cagas and Dr. Laura Parnas. Dr. Cagas is Scientific Affairs Manager in Medical and Scientific Affairs for the Molecular Diagnostics Division of Roche Diagnostics Corporation. He has experience working directly with customers and performing quality investigations during the manufacturing process. Prior to this, Stephen was Principal International Product Specialist and assigned Product Champion for Roche Donor Screening and Genomics and Oncology Companion Diagnostics. Dr. Cagas directly interfaces with clinicians and opinion leaders to assist in the commercialization of products within the Roche Molecular Diagnostics portfolio. He is also acting lead for scientific projects related to donor screening and microbiology. Dr. Cagas earned his PhD in microbiology and molecular genetics from University of Medicine and Dentistry of New Jersey, currently Rutgers University, working with the president of the Public Health Research Institute Center on projects aimed at discovery of novel biomarkers to treat patients with opportunistic pathogen infections. Dr. Cagas completed his postdoctoral fellowship at the Institute working on collaborative projects as part of a Department of Defense initiative. Dr. Laura Parnas is a Senior Scientific Affairs Manager at Roche Diagnostics, supporting educational, clinical, and scientific activities within the non-cardiac and personalized healthcare diagnostics portfolio. Dr. Parnas joined Roche from Sutter Health, where she was the Director of Clinical Chemistry at Sutter's Shared Laboratory, responsible for the oversight of the clinical chemistry, special chemistry, and immunology sections. Prior to that, she was Associate Medical Director for Laboratory Services at Sutter Health's Palo Alto Medical Foundation. Laura earned a PhD in biochemistry and molecular biology from the University of North Dakota and completed her postdoctoral fellowship at the University of Utah and Arup Laboratories. She is a diplomate of the American Board of Clinical Chemistry, as well as an active member of the American Association for Clinical Chemistry. Dr. Cagas and Dr. Parnas, we are glad to have you present today. You may now begin the presentation.
Thank you very much, Joyce. And on behalf of Laura, I want to say thank you to AACC for allowing us to give this education. And at first, we're going to start with the disclosures. So myself and Dr. Parnas are both employees of Roche Diagnostics, and we both function in the non-commercial medical and scientific affairs division. Everything that we're going to present today is educational in use and in line with FDA guidelines. The most important piece on this slide actually is all the way at the bottom. The information presented here is current as of April 18th. And if anybody has been involved in the recent coronavirus outbreak, they will know that every day seems like a lifetime. So the information has changed significantly, but we're trying to present the most current data that we possibly have. So a short agenda for today. The first thing we're going to talk about is a little bit of background and some epidemiology on the novel coronavirus, and some information on tracking SARS-CoV-2 and COVID-19. We'll describe what those terms are, the different testing modalities, and some testing hurdles that we've seen. Then I'll turn it over to Dr. Parnas, and she will be talking to you about biomarkers and serology and some potential therapeutic approaches. And then towards the end, we'll get to some Q&A. So everybody's been talking about this novel coronavirus, and just to ground us on what this is and where it came from, we're going to start with a little bit of history. And ultimately, this novel coronavirus started in the Wuhan city of China and was first described from a group of cases of atypical pneumonia on the 31st of December 2019. So everything that we're going to describe in this entire webinar is basically taken place in the past 4 months. So this timeline is extremely compressed. Ultimately, about a week later, there was an official causative agent, and a genomic sequence was released on or about the 7th of January. And about 3 weeks after that, a month after the original discovery, there was a declaration by the World Health Organization of a global emergency. And a little later, we'll have all this information on a timeline that will help you sort of visualize it. The agent that causes the disease that we're seeing is SARS-CoV-2, or SARS coronavirus number 2, and the disease that results from getting SARS-CoV-2 has been named COVID-19. So what are these coronaviruses that we're talking about? Well, first of all, there are enveloped RNA viruses, and they tend to be very large. They are zoonotic, meaning that there's transmission between animals and people. Often the widest, the reservoir most seen for coronavirus is actually bats, and but mammals actually serve as intermediate hosts generally with these viruses. Not all coronaviruses are actually pandemic strains. There's about 5 to 10% of all respiratory tract infections, common cold, other things like that, actually tend to be because of coronaviruses. But there have been 2 pretty severe outbreaks of coronaviruses in the past. The first being SARS, the original SARS coronavirus in 2002 in China, and the Middle Eastern respiratory virus, or MERS, in 2012 that came from the Middle East and Saudi Arabia. The picture on the right is actually pretty important here, and the reason being that in a lot of assays that are specific for molecular testing, you're going to see what targets they have. And these targets, you can notice on this picture, you can see that they have letters associated with them. So N for the nucleocapsid protein, E for the envelope, or S for the spike. A lot of other targets are within the actual genomic material inside. So this is going to help to ground you if you ever start to look at the different targets for these different assays. So a little bit more on the original SARS coronavirus and MERS. I said that mammals often serve as an intermediate host, and for the original SARS coronavirus from 2002, that was actually civet cats, and for MERS coronavirus, it was camels. And one thing you'll notice here is that the mortality rates for the original SARS coronavirus were a little less than 10%, and for the MERS virus, it was about 34%. And we know that this coronavirus is, and these numbers have not been nailed down by any stretch, but we know it's quite a bit lower than that, probably somewhere in the neighborhood of, numbers range, but somewhere in the neighborhood of 1 to 3 or 4%. An interesting fact that we'll come back to in a little while is the distribution that you see. So the original SARS coronavirus was distributed throughout 29 countries, and the MERS coronavirus was about 27 countries. So the information that's on the left we discussed a little bit already, but I want to kind of look at the picture on the right. So we know that, again, there are these intermediary hosts that are mammals, but these coronaviruses tend to come from bats. And so like I said, for the original SARS coronavirus on the top, you can see that's a shadow of a civet cat. On the bottom for MERS coronavirus, that's a picture of a camel. And then ultimately these get transmitted into humans. For the novel coronavirus, that link has still not been established. They believe it's an animal that's related to an aardvark called a pangolin. There has been some recent studies that have found related coronaviruses to SARS-CoV-2 in pangolins, but this link has not yet been fully established. So we talked about the virus itself, SARS-CoV-2, but then there's the disease that it causes, which is COVID-19. So what are some of the signs and symptoms of this disease itself? So symptoms tend to be fever. There are respiratory symptoms. Obviously, it's a respiratory illness. You would expect that. With abdominal pain, there have been some gastrointestinal. So some folks have seen diarrhea, vomiting, that type of thing. And the clinical presentation, actually, I'm going to go back to those symptoms one more time. There have been anecdotal stories, however, nothing proven yet, that some people actually lose their sense of smell and or sense of taste, which is an interesting dynamic. These are anecdotal, not there. I haven't seen anything in the scientific literature to back that up. In clinical presentations, you can go from asymptomatic infection, which will actually become very important a little bit later when we start to talk about both the serology and some of these molecular tests. You can have mild illness, and it can go all the way through very serious illness up to fatality. Transmission is person to person at this point, and there's an incubation range of about 2 to 14 days. And again, it can cause a very severe respiratory disease and clinical progression. There is classifications of the different COVID-19 pneumonia diagnoses. So you could have mild, as we said, almost asymptomatic, or very mild symptoms. Then you can go through moderate, where some signs of pneumonia have been seen. Ultimately, there are severe cases, critically severe cases requiring mechanical ventilation. And then there's a whole list of criteria that are here for children. We know that children tend to be a little bit less affected by this than adults, and particularly the elderly. But you know, all this information is available for you to review. So I'm going to show a few different screenshots of a tracker that has been developed by Johns Hopkins University, and I'm going to show it over a couple of different points at which we've been monitoring this particular coronavirus. And the first screenshot shows what the outbreak looked like on the 27th of January. And what you can see here, if for the keen observer, is up here on the title. It was actually called, at that time, still 2019 novel coronavirus, and it was still listed as the Wuhan coronavirus. Obviously, the information has been updated to call it SARS-CoV-2 at this point. But more importantly, what you can see here is that the number of cases and the geographic distribution of the cases is actually quite tight in China or in the parts of Southeast Asia, and mostly this was still only a disease that was affecting mainland China. As you can see, you can look at the information on the right with the number of cases, the number of cases outside of mainland China, and you can see that they were very, very low. About a month later, we gave an internal webinar, and this was the screenshot from that day that we gave this webinar in the 23rd of February. And now you can see that they are that the cases are much more distributed. You can see that this was just about the time that it was starting to become that Italy was starting to see their spike in cases. And what you can see is the number of total confirmed cases went up significantly, as did the number of deaths that were associated with it. And again, the geographic distribution. I remember one thing I can certainly tell you about this is that when I saw this number 35 for the US, if you look on the left-hand side, you can see the 35, that at that time, over half the cases out of those 35 were associated with a cruise ship. So we were still in the teens in the number of cases that we had seen at this point in the end of February. Fast forward another 2 months, and the latest data that we have right now is that we are up over 2.2 million, and clearly, if anybody were to look at the data today, it's going to be higher than that. 2.2 million cases, with the majority being in the US, Spain, and Italy, and we're well over, unfortunately, 150,000 deaths overall. And you can see here on the bottom, on the right-hand side, is the curve of number of cases that are confirmed over time. And I told you before that MERS and the original SARS coronavirus affected somewhere in the neighborhood of just under 30 countries. You can see now that SARS-CoV-2 is affecting 185 countries and or regions across the world. If we zoom in on the United States, what does the distribution of cases look like in the U.S. itself? You can see that there's a cluster of cases that are obviously in the Northeast and the New York area. However, every state in the union has cases of confirmed coronavirus. There have been over 37,000 deaths at the time of this recording and over 700,000 cases across the country. The interesting piece is that they started tracking the total number that are tested in the U.S. here. So at this time, there were 3.5 million tests administered by the date of this recording again. So the number of tests, obviously, we're going to get into the testing a little bit in a couple of slides, but I wanted to bring that up. This information is available to anybody. You can see the link at the bottom, and you can feel free to kind of track all these different pieces of information. They have information on active cases and incidence rate over the course of every state, fatality ratio, testing rates, hospitalization rates. So you can use this information. But I actually want to show you other resources that can get you similar information through different means. And I thought that these are really good resources, both for yourself and for the institutions that you work for or work with. The first is on the left-hand side. This is a website called NextStrain. And this is really, really interesting for anybody who's kind of involved in epidemiology or who cares about that kind of thing. I can say that I kind of geek out on that a little bit. But on the left-hand portion on the top, you can see all those dots. All of those dots represent sequencing data that has been uploaded into a common server, and folks have been sequencing the coronavirus all over the place and then using epidemiology and the sequencing to try and trace back the origins of the coronavirus. And the panel on the right might look a little bit like a spaghetti bowl, but actually you can see in small letters, you can see the play button there. You can actually play this as an animation. So I would encourage folks to go on this website. You can play this as an animation and start and watch the actual virus spread and the linkages between the different countries about how it's spread over time. On the bottom of there, you can see those different colored bars, and what those bars represent are the different open reading frames or different genes. So again, if we went back to that first picture that I showed and I was telling you about the different targets that different assays use, you can see all of the different targets that would be on a particular assay on this open reading frame chart. On the right-hand side, this is a different way to look at some of the information. This is from the Institute for Health Metrics and Evaluation out of the University of Washington. And on the top, it's showing projections. So this is where a lot of the projection data you've been seeing maybe in the mainstream media has come from, which is the number of deaths per day across the United States, the rate of hospitalizations and the information that's going to be needed for hospitals, and then the overall death rate expected over this. So again, you can look at this and see what the projections are and what the information looks like going forward. A little bit more information here on the left. This is from a website called USA Facts. This is a nonprofit, nonpartisan organization, and they compile publicly available government data. And once again, the thing I like the most about this piece of data is that you can play this information as animations. So you can see this, the information that's being presented in the screenshot is actually confirmed cases, again, as of the day of the recording. But this is broken down by state and by county. So you can click on any state or any county, and you can show what the outbreak has looked like over time. And you can do this for overall confirmed cases, cases per 100,000 residents, and deaths. And you can actually watch these, watch the pandemic sort of and its dynamics and how it's spread. Finally, the one place where you wouldn't necessarily think would give you a vast majority of your scientific information, but actually Google has provided a really interesting resource, especially when it comes to flattening the curve, which I'm going to talk about in the next slide. But everybody's trying to understand how are we doing about staying home and seeing all these different things that we're doing and is there an effect on where we've been going and what we've been sort of doing to try and flatten that curve? Google has used information, they're tracking basically cell phone usage and geolocation, and what they've come to realize is that we've made dramatic decreases in our location data. So retail and recreation, we're not going out to stores as much, neither the grocery store, obviously a little bit less, but 45% reduction in retail. This is across the country. This information is available for every state, again, and you can even drill down to every county in every state. Google will provide this information. So you can see the dip in workplaces, that we haven't been visiting our workplaces as much as you would expect. Transit stations, again, being airports and bus stations, but an increase of 14% in residential, meaning, again, as expected, we're staying home a lot more. So what do we mean by flattening the curve? We've seen this, we've talked about this. This has been everywhere in the mainstream media, but essentially what we're trying to do is reduce the number of cases that happen all at once to be able to deal with the healthcare system capacity that we have. I'll present my very embarrassing thing that I've become an amateur baker while I've been trying to flatten the curve at home. What we're going to do is I'm going to show this slide, and Laura will be, Dr. Parnas will be showing the slide a little later also. And this is the information talking about when you can expect to see certain things happening and when certain testing might be the most appropriate. So on the left-hand side, you can see it says viral load, and there's that black curve, and that's for NAT testing. So nucleic acid amplification technology, or NAT testing, works best very early on because it's actually detecting the genetic material that's inside of the virus. And then ultimately, and I'm going to leave all of this to Laura, but ultimately moving past that, then the serology piece comes into it. So this was the timeline I was alluding to a little bit earlier, and there are some other pieces on here that I wanted to touch on. Again, 31st of December is when the cluster of unknown pneumonias had been reported to the WHO. The new coronavirus was identified on the 7th, but within another week, the WHO released their guidance on testing. And 4 days after that, there was a publication on a real-time PCR assay to start doing that testing. Ultimately, a few weeks after that time point, on the 4th of February, the Center for Disease Control released their emergency use authorization assay via real-time PCR. The first commercially available real-time PCR research use only assay was available in the US on the 14th, outside of CDC's assay. Ultimately, the first commercially available real-time EUA assay in the US was available on the 12th of March. So there are some data points on the bottom that I will leave you to read at your leisure. So I talked about this EUA, Emergency Use Authorization. What exactly is this and what does it mean? An Emergency Use Authorization is basically used to help strengthen the nation's public health protections against chemical, biological, radiological, or nuclear by facilitating the use of medical countermeasures during a public health emergency. So translation of that is basically in the section in the middle, which is that the FDA commissioner may allow unapproved medical products or unapproved uses of approved medical products to be used in an emergency to diagnose, treat, or prevent serious or life-threatening diseases when there are no adequate, approved, or available alternatives. So essentially, the FDA is allowing a little bit more leeway, again, within the constraints that they set. Specifically for molecular assays, this guidance was put out on the 29th of February. That was also in the timeline, but was updated on the 16th of March. For folks that are looking to do an emergency use authorization assay for a molecular diagnostic, the FDA has outlined that they basically need to fill 4 criteria. Now, this is not an exhaustive list, and the full guidance is available on the link, but in terms of what they suggest, there is a limit of detection assay, which is essentially three replicates per concentration, and then they want you to confirm with 20 replicates at your lowest concentration. A clinical evaluation, which is 30 positives and 30 negatives, and they want 20 of those 30 to be at about 1 to 2 times your limit of detection, and inclusivity and cross-reactivity study, and both of those can actually be done in silico. So this is, again, a little bit different. The full list of information, like I said, is again available on FDA's website, but this is, for folks who are in the molecular world, this is a bit of a departure from what would normally be seen with an IVD assay. But suffice it to say that this has helped a lot of folks get testing much more quickly, which is very, very important. Who gets tested is the next question that is often asked. CDC has set up criteria, WHO has set up criteria, but the summary basically is that we can use NAT testing for diagnosis, and that that testing is needed to inform the clinical decision making, and we need to prioritize testing when the availability is limited, and availability has been limited up to this point. So CDC has put out some information, and you can see it here, and the information is available publicly. But basically, their testing priorities have been, they basically tried to bucket it into 4 groups. And again, this is today, this may change in the future, but right now, priority 1 are inpatients and healthcare workers with symptoms, obviously. Priority 2 would be long-term care facilities, the elderly with, again, all with symptoms, long-term care facility with symptoms, elderly with symptoms, underlying conditions with symptoms. And then we get into priority 3, folks with mild symptoms, asymptomatic healthcare workers and first responders, anybody with symptoms, and then ultimately what they're listed as non-priority are individuals without symptoms. We can all know that there have been testing resource limitations up to this point. On the left-hand side, I'm showing a picture of transport media and a swab. I would guarantee that everybody on this call, nobody would have thought that supply chain and plastic swabs would have been the most important thing they would have been talking about for the past couple months. But these have been limited for a variety of reasons, but folks have gotten quite creative, and we can talk about that a little later, but folks have gotten, the limitations on swabs and media have gotten to the point where, number one, the president during one of the press briefings actually pulled a swab out of his pocket and was showing what it looks like, and has implemented the Defense Production Act to increase production of swabs. So there has been a resource limitation in the swabbing area. Medical personnel, the folks who have been taking care of us, the nurses, the doctors, the frontline workers, as well as the folks that are within the laboratories, have gotten sick, not necessarily because they are working with COVID. They may have gotten sick outside, but we need these folks more than ever to be available on the front lines, and sometimes they get sick also. PPE, personal protective equipment, we've heard about this a lot of different times about the lack of personal protective equipment and the resource limitations around that. And again, folks have gotten pretty creative on ways to, the testing modalities have changed a little bit on how to use PPE more effectively. And then ultimately the testing capacity itself, the actual ability to do the testing, has been limited across the U.S. For, again, a variety of reasons that I'm sure we will talk about. But up to the 18th of April, what are the current technologies that are available for testing right now? I would say that the first is these high throughput molecular systems. So these systems can do the PCR-based assays that I talked about a little bit earlier. They can do them at high throughput, so several hundred or even several thousand per day can be performed on one of these systems. There are the point-of-care molecular assays. So these assays are the ones that you may be seeing on in the mainstream news, and especially at these drive-through facilities. And the last group fall into these rapid lateral flow immunoassays, which are in the serology world. And Laura is going to definitely be able to give you a lot more information on the serology assays themselves. So I'm going to conclude, and I'm going to pass it to Laura to start talking about serology.
Thank you, Steve, for a very informational presentation. As we continue to learn about the SARS-CoV-2 infection, we know that every day more and more articles are published in all aspects of the pandemic, including those that describe clinical characteristics of COVID-19 across the world. In this graph, you can see a proposed clinical classification that splits the disease according to 3 degrees of increasing severity that correspond with distinct symptoms, biomarkers, response to therapy, and ultimately outcome. During stage 1, that mild stage during the early infection, this happens at the time the person is infected with the virus and the disease is pretty much getting established. For most, at this stage is thought to be where the incubation happens, and many exhibit mild and nonspecific symptoms. In the meantime, SARS-CoV-2 is multiplying within the respiratory system. In the second stage, what we call the moderate stage, pulmonary disease is established. The virus is multiplying in the lungs, and the first signs of inflammation start to display. And at this stage is where the patients start exhibiting signs and symptoms of viral pneumonia, and hypoxia can be present. So if the patient starts displaying hypoxia, mechanical ventilation could potentially be necessary. Some patients will unfortunately evolve to stage 3, which is the most severe in the disease, and is characterized by a systemic hyperinflammation syndrome driven by the inflammatory host response. The prognosis at this stage is poor. So in the next slide, I will describe each one of these stages and the role the laboratory plays at every single one of the stages. During stage 1, this mild early infection stage, only minor non-specific changes in laboratory parameters have been observed, including slight decreases in the lymphocyte counts and mild increases observed in D-dimer and LDH. During stage 2, when the pulmonary phase is developing, mild to moderate changes in laboratory parameters are observed in this patient. Mild increases in transaminases have been reported, which indicate there's additional liver compromise in this patient. Procalcitonin, which is a marker of bacterial infection, is usually within normal ranges, but some reports have shown mild elevations, which can indicate a bacterial co-infection is present. CRP or C-reactive protein concentrations can be normal or elevated, especially during that hypoxic state where the inflammation is starting to develop. And mild elevations in ferritin, which is an acute phase reactant, have been reported. Elevations in lactate indicate tissue hypoxia and organ damage. During the most severe stage of COVID-19, this hyperinflammatory host response, many laboratory parameters are significantly affected. As expected, CRP and ferritin show significant elevations. IL-6, a cytokine released during early acute inflammatory processes, is significantly elevated, and there's some evidence that it could be linked to disease severity and progression. And PCT, again, can be normal or elevated, indicating that a bacterial infection, co-infection could be present, which is especially important in patients that are receiving mechanical ventilation. The cardiobiomarker changes reflect cardiac involvement, especially for severely ill patients that have cardiac-related comorbidities. Inflammatory biomarkers have now moved to the forefront as indicators of disease progression and severity in COVID-19. Both IL-6 and CRP have been included in the Chinese guidance for COVID-19, the 7th edition, as warning signals, quote unquote, for severe and critically ill severe patients. Additional helpful biomarkers at this stage include lymphocyte counts and lactate as well, that are included in the guidelines. There are some reports that have associated both CRP and IL-6 with mortality. For example, in this retrospective multi-center study of 150 hospitalized patients with confirmed COVID-19, we see on the right-hand side panel, there are 4 biomarkers that are significantly increased in patients that died compared to those patients that were discharged. So as you can see in the graph, the differences in concentrations between the 2 groups across all biomarkers are statistically significant, suggesting an association of higher concentrations and increases in mortality. And this can be seen in other reports that are similar to this one. Another syndrome that has not resurfaced is what we know as a cytokine storm or cytokine release syndrome. Several studies suggest that a subgroup of patients with severe COVID-19 may develop a cytokine storm. The cytokine storm involves the production of pro-inflammatory cytokines such as IL-6 and is associated with a variety of infectious diseases. Also, cytokine storm is a common treatment-related toxicity that is associated with CAR T-cell therapy. At the moment, research is ongoing to determine whether cytokines can be used to predict the cytokine storm severity. And finally, tocilizumab is an antibody agent against the IL-6 receptor, has been a standard cytokine storm treatment. And I'll talk a little bit more about potential therapies later on. Steve talked about the structure of the coronavirus previously, so I will revisit it in a different, from a different angle. Here you have the structure of the SARS-CoV-2. So basically it comprises of spikes, which are formed by the spike protein consisting of two subunits, S1 and S2. S1 contains what we know as the receptor binding domain, which is responsible for recognizing and binding with the host cell receptor. Spike protein is a common target for neutralizing antibodies and vaccines, while the amino acid terminal side of S1 subunit of the spike protein is the most variable immunogenic antigen. Additionally, SARS-CoV-2 has a nucleocapsid protein, which is the most abundant viral phosphoprotein produced and shed during the infection. This nucleocapsid protein exhibits high immunogenicity as well. Furthermore, SARS-CoV-2 contains a membrane glycoprotein, which is the most abundant protein on the complete virion particle. And the envelope is the smallest major structural protein of SARS-CoV-2, which is involved in viral assembly, release of virions, and pathogenesis. The two bars below the main virus graph show in comparison the structure between the spike proteins of SARS-CoV-1 and SARS-CoV-2. Another slide that Steve showed you before are some of the current assumptions for the SARS-CoV-2 infection as what we're learning over the past 4 months since we have encountered this new virus in humans. And as you can see, there is an initial viral load that peaks that starts with symptom onset and peaks around day 3 to 5. But all the evidence that we have seen in the literature so far are that IgM and IgG start rising pretty much together. So a combined IgG and IgM detection potentially has higher sensitivity than the detection of each immunoglobulin alone. And then the median seroconversion, again, this is up to the literature that has been published so far, it's about around day 13. I will describe now some of the serum antibody responses that that have been published in some patients that have recovered from SARS-CoV-2 infection. In this case, I'll describe in these pictures an observational cohort study. For this particular cohort study, most patients have rising IgG and IgM antibody titers 10 days after the symptom onset. IgA antibody titers have also been shown to be increased at a similar time period. Serum IgG amounts can rise at the same time or earlier than those of IgM against SARS-CoV-2. And for 16 out of 23 patients with serum specimens available for 14 days or longer after symptom onset, the rate of seropositivity was 94% for anti-nucleocapsid protein IgG, 88% for anti-nucleocapsid protein IgM, 100% for the RBD domain IgG, and 94% for the anti-RBD domain IgM. And the serum antibody levels still are not very well correlated with clinical severity. Several studies are now undergoing to determine how that happens, and the longitudinal studies over samples in patients are currently undergoing. I think it's important to understand, since already Steve has described the nucleic acid testing and the differences between nucleic acid testing and serology in SARS-CoV-2 infection and COVID, and how we can potentially use these two different test modalities. For the nucleic acid amplification test, they actually detect the presence of the viral RNA in the sample. So they provide information about current infection with SARS-CoV-2. In terms of the serology assays, they measure whether antibodies are present in the patient sample. So they will demonstrate the presence of an immune response when the patient is exposed to the virus. So there are some potential uses of serology assays. One of the main uses will be to determine exposure to SARS-CoV-2, and this will be very helpful in seroprevalence studies. So right now, we don't know a lot of how many people have been actually infected with the virus versus because we are now in the testing mode to actually detect active infection and test mainly those people who show symptoms. Also, serology could be helpful for community screening, for contact tracing, for epidemiological studies to determine immunity and to determine who can go back to work. What we don't know in terms of how we are going to use the serology assays. We don't know whether the immunological response that is mounted when the person is exposed to the virus is actually protective. Those studies are also underway. Does the presence of the antibodies indicate immunity? We don't know yet. How long does that immunity last? Does the person need to be exposed multiple times, or do these antibodies will last longer periods of time? And also, we don't know what kind of antibodies will a safe and effective vaccine generate. We know there are several vaccine trials undergoing, but we don't even know how fast the immune response to the vaccine will be generated. And also, we don't know how long will the vaccine be protected for. Also, we don't know, there are some modeling estimations, but we don't know how long it will take to reach herd immunity in the population. And we also don't know how many times will an individual need to be tested. So these are some of the questions. Of course, they're not all the questions that we can think of, but we try to be inclusive of all the thoughts that we have been hearing. I will now switch a little bit into what the regulatory pathways for the serology assays are, which are slightly different than what Steve described for the molecular tests. So there are actually two pathways for serology assays to be offered by laboratories. So the fastest path is the first one that is described in this table, is basically no emergency use authorization is required. So the test cannot claim that it can be used for just to diagnose or inform the infection status, and there are 4 disclaimers that need to be included on the test reports. This only requires, in terms of the FDA, an email notice of distribution to the FDA, and manufacturers can start distributing immediately. There's another path, which is the emergency use authorization path, that it has certain criteria. So the first is a pre-EUA submission for FDA to evaluate the intention of the manufacturer to submit the assay for EUA, and then finally an EUA submission to FDA. And then the lower part of the table is describing what Steve already touched upon for the molecular test. And some of the studies that are needed for the serology submission for minimum validation studies recommended by FDA are listed here. The audience in this webinar, I'm sure it's very familiar with this. Cross-reactivity and analytical specificity, manufacturers have to submit this information. Class specificity, a clinical agreement study, and then also sample types and matrix equivalency. So FDA recommends that clinical accuracy should be established on human specimens from patients with microbiologically confirmed COVID-19 infection. And in the lower part of the table, what Steve has described is there. And finally, I wanted to touch upon the therapeutics that are being evaluated for COVID-19. And again, my big disclaimer here is that these are only experimental at this time, only to be used in the context of clinical trials. So in the top part of the table, you will see those what we call the repurposed agents. These are agents that are already available for other purposes. So the first one is the Caletra, which is an HIV protease inhibitor, is being considered for trials. Chloroquine or hydroxychloroquine, which is a malaria drug also used for lupus patients. And then Arbidol is another S-protein ACE2 membrane fusion inhibitor, which tries to take advantage of the mechanism of entering the cell that the SARS-CoV-2 virus has. In terms of a new investigational agent, remdesivir is an antiviral that was generated to fight Ebola, and it's shown to be ineffective in that population. So now the trials are undergoing to see if this agent will be effective for COVID-19 patients. Then we also have apitegromab. It's a new agent. And then finally, we have the adjunctive therapies. Actemra is, and I mentioned that before, tocilizumab is an IL-6 receptor inhibitor, so it's thought to potentially be helping COVID-19 patients that are undergoing a cytokine storm as potentially an immunomodulator. And then finally, the deferoxamine has also been proposed for trial in these patients, and it's an iron chelator. And finally, in this graph, you have the different mechanisms of action of these drugs that have been proposed to be effective in this particular subset of patients. And you can review the slide later on when you get the slides. That basically is exactly where different pathways through the process by which the virus enters the cells and reproduces. So that is the end of my presentation, and I think that we will open the audience for questions.
Thank you, Dr. Cagas and Dr. Parnas, for sharing your excellent presentation with us. Yes, so now we'll begin the question and answer session. And I'm going to start with the first question, and that is, will there be a role for nucleic acid amplification testing or PCR-based testing in the future as serology becomes more critical?
Laura, I'll take this. Yes, I think that PCR-based testing will still hold a very active role moving forward. So I think that the role of NAT testing and serology testing will be complementary moving forward. I think that ultimately we're still going to need to diagnose active infections, and we're in that process right now, obviously very active in that process. And as Laura mentioned, this concept of back to work will need a strong serology component, but I think that folks are also going to want to continue to test for active infections before the idea of back to work is implemented. So I think that these are going to have to play complementary roles to each other. I don't think it's going to be one technology or the other. And frankly, I think that there's roles for multiple areas of technology. Again, I talked about those high throughput systems for the majority of testing, again, in conjunction with point of care testing or near patient testing, in conjunction again with serology testing and the different types of serology testing that Laura described so eloquently.
Thank you. Okay, this question is about guidelines. Are there any guidelines or published algorithms for testing?
I will take this one, and at the moment there are no guidelines published that indicate algorithms for testing. So we believe that CDC is working on some testing guidelines, but so far there are no official published guidelines that indicate an algorithm for testing in these patients.
Okay, another question is, what happens after the FDA's Emergency Use Authorization designation for an assay expires?
I will take that one as well. And after the FDA Emergency Use Authorization expires, what happens is that manufacturers have to submit to do a submission to FDA. A full submission on either pathway, either 510K, 510K Novo, or PMA to get their assays approved by the normal regulatory pathway. So it needs to be a strategy to ensure continuity of testing by manufacturers by making sure that they will submit their testing, their assays for the regulatory pathway, the normal regulatory pathway with FDA. And FDA has also made that clear to manufacturers.
Okay, thank you. This question is regarding the shortages Given the shortages that you described, what other solutions have labs come up with to try to alleviate the significant strain on resources?
Yeah, so I think I used the word during my presentation, but the word creative is the operative word here, and necessity truly being the mother of invention. A lot of manufacturers have done different things to try and address some of the shortages. So one of the shortages, again, was swabs. That was one that I mentioned. I've seen reports of folks who are asking about using 3D printed swabs. So that's somebody had that idea, which is amazing that somebody could even think to do that. Last week or earlier this week, the LabCorp got approval to have a at-home collection test, so you can actually be tested in your house. So that obviously reduces the need for personal protective equipment for frontline workers, and it could really help alleviate some of those bottlenecks. I mentioned drive-through testing. I don't think anybody would have ever thought that we would be using parking lots to have actually drive-through testing. That's a very, very new one. Another one was actually really interesting is, again, to try and reduce the amount of personal protective equipment required, is being able to use self-collected but clinician-instructed swabs. So you can actually stand a safe distance away if you're a clinician and actually collect the sample. A clinician can instruct you, the patient, on how to collect the sample yourself. Other things are the use of nasal samples. These are some other things that have come up, through the manufacturing process and ways that we've been trying to, again, expand the idea of testing. One is, like I said, the use of nasal swabs rather than nasopharyngeal swabs. From what I understand, it's not a very comfortable swab to take, and it's not a very comfortable swab to have taken. So using nasal swabs is much easier on the patient and on the healthcare providers. Another thing is the use of alternative media. So I talked about how media was also, there was a shortage of collection media, and manufacturers have been able to use saline, so sterile saline as a collection media. And besides water, saline is probably the most common liquid in any healthcare setting. So there's an abundance of saline, and a lot of manufacturers have been trying to use saline there. So I think that, like I said, there's been a lot of work by a lot of different folks within the industry and the organizations to try and expand the ability to test using a lot of different modalities. And like I said, creative certainly is the operative word.
Thank you. Thank you for your insights, Dr. Cagas and Dr. Parnas. This actually concludes our question and answer session. I would like to, again, thank you both for providing your time and expertise for this presentation. It's been very informative. And also thank all of those in the audience watching this AACC educational webinar, again, made possible by the support from Roche Diagnostics. I just want to thank everyone, and I hope that you all have a wonderful rest of your day.